No, I think it's important that you understand. We are celebrating 50 years of innovation by Straumann because the first prototypes were made in the 74 by Straumann and Andre Schroeder. By the way, you might have seen my post 2 days ago. 2 days ago, we remembered Andre Schroeder because 20 years ago exactly he passed away. And he was so important man for ITI's development. And that's why I wanted to do that. I don't want to discuss this slide, of course, but I want to show you that the improvements were made over the years based on clinical experience, a lot of research. And now we are talking about, then soon, about the fourth generation, which is a very logical one. Now, I got involved in 1984-85 with the second generation when we went from one piece to two piece. And then we started to place implants. These two-piece implants. The main implant type we learned very quickly was the full body screw, type S. And you see here some of the long-term cases. And most impressive, the long-term stability of these tissue-level implants over the years. And if you don't believe me, talk to the people who use these implants. They will confirm that. I hear that all over the place, how stable these implants are in the tissues. And that's a very important part. And you see here the radiographs. That means in the transcrestal area, you have a smooth surface. So this is not prone to be accumulated by plaque. And therefore, the tissues are able to stay healthy. And you see how stable they are over the years. Up to 37 years here, a hollow screw implant. Still alive, 84 years old. And I hope she will turn 100. Then we're going to have more than 50 years of documentation. Okay. Then when aesthetics became more important, platform switching was introduced in the United States by III and these guys. And then we wanted to have also an implant with a platform switching concept. And these were then finally the bone level implants, because then you have less remodeling in the crestal area. And the bone level implants first straight and then tapered, and then BLX have been introduced by Straumann. This is the third generation. And it was mainly done in the aesthetic zone. And we had a very good experience with single tooth replacement in the anterior maxilla. And we also had them used them in two central incisors and so on. We started with the bone level straight. And you see here a 10-year case that represents the original group of patients we treated in 2005, 2006. And then, of course, also with two adjacent central incisors. You will not get with tissue-level implants this type of result because you maintain much better bone in between the two implants. Later on in 2017, I switched over to the bone-level tapered implant because I figured out we get better stability. It was a big improvement for immediate implants when I started to do those. So I became then primarily a BLT user about 7 years ago. Why not in the posterior? I tell you, I was very excited about that implant, but when we used them in the posterior distal extension situations, I have seen many of these cases in my clinic, and then I talked to other ITI fellows half year later, and they said they see exactly the same. I stopped to use bone-level implants in 2009 in posterior areas because I didn't want to grab them so deep into the tissues, because I figured out for posterior tissue level is serving me much better. That's why in our clinic, 15%, 18% bone level implants, more than 80% tissue level implants for many, many, many years. Okay, what's the problem? If you get an exposed micro-rough surface, we have an increased risk of peri-implantitis. And when you really read the literature and the systematic reviews, we realize that we have a big problem in the market. And I hear that everywhere. You see, a pandemic of peri-implantitis, according to these systematic reviews, 12 to 28%. In particular, when an exposed micro-rough surface is combined with another risk factor, smoking, perio-risk patient, whatever, then you get infections. And we have learned that the surgical performance of the clinician is a big risk factor. I will talk about that tomorrow. And of course, the micro-rough surface exposed. And I will show that tomorrow as well. Here you see the Dirks paper that really was an eye-opener for everybody. much better performance for Straumann tissue level implants compared to Bronnemark and the AstraTech implants from a Swedish group, and that was really very important information. And therefore, you see, this is also a nice comparison. 2 10-year studies, one from burn tissue level, one from Belgium, and AstraTech implant. You see the complication rate at 10 years, 3% on one side, 17% on the other side, and factor 5 plus. That's like in Dirk's paper, because there was the same odds ratio there as well. So we started to discuss with Straumann around 2016. I remember that was actually it was in Stockholm with Marco Gazzola, that why not move into a 4th generation? And here I hand over now to George, because he will talk you what the discussion was at Straumann level from 2016 on.
Danny, thanks a lot. First of all, it's very humbling to share the stage with you. Welcome, everyone. It's a great pleasure to be here with you today. Now, I don't go back that much as you, Danny, and probably you're one of the very few persons on the earth that has 40 years of follow-up data on implants. But still, I would like to take you back a little bit to also explain what actually has driven us to create the iEXCEL system. And as you mentioned, let's go back to the year 2016. At that point in time, we just started with the BLX development. And you can imagine, I mean, we were super excited to finally have a fully tapered implant line in our portfolio. And as we normally do, we then go out to KOLs, we talk to you, we talk to many other people, and we wanted to have feedback, well, how will this portfolio extension actually land with you? Would that be of service? How would the entire portfolio shift once that we introduced it? And well, the feedback was, let's say, interesting. So on one hand, there was a lot of positive feedback in the sense that, yes, we do need a fully tapered implant because immediacy is really something that is upcoming, and a lot of patients, they could profit from slightly different endosteal shape. But then we also got a lot of feedback in the sense that, guys, are you realizing how you make our lives quite complex? I mean, you have started to develop implants 30 years ago, and you still sell them, which makes a lot of sense. But overall, the system has become quite complicated. I mean, we got a lot of feedback. Yes, we're not using all the implant lines, but we're using at least a couple of them. So all with different drill protocols. And you see here the lineup of 8 implant connections. And at that point in time, we still planned to have actually 2 implant connections on BLX. And on all of those implant connections, there will be prosthetic lines. They need to be managed. And on the prosthetic lines, they need tertiary components. So the feedback that we got was, yes, we need new products, but actually, can you please think in terms of not just bringing one disconnected implant line after the other? Can you start to think about creating or recreating an entire system? And in essence, what you, as our customers, gave us feedback on is, please create a simple system. And from an R&D perspective, I can tell you the most complicated skill is to create a simple product. But we took this to our heart, and actually we started thinking about the vision that we had for this new system for iEXCEL. And on one hand, of course, we wanted to use all the technological and clinical advancements of the last couple of years that also, Donny, you mentioned so nicely. The tissue level concept is biologically a very, very feasible and even better concept for some of the indications. So we wanted to rejuvenate, hence TLX and TLC later on. But we also wanted to drive it one step further. And Holger mentioned it in the introduction. So it is about creating a very versatile system, but at the same time thinking about what can we make simpler for the clinical practice. And we put out 3 goals that we wanted to achieve. First of all, why not go back to the roots and just try to do it all with one surgical kit? Secondly, we really need to rethink our approach to different implant connections, because that's a multiplier for complexity. So why not setting the goal of creating one connection? And last but not least, when we're creating a system, there is the opportunity to create a lot of multifunctionality for components. So this could be, as I see it here, for the implant drivers. So you shouldn't be forced to use different implant drivers on one system approach. So in a sense, you can think of us starting to play Lego. So we started to think about iEXCEL like the Lego system. With few parts, you have a lot of creativity, you have a lot of options, but everything is built around one single unified connection, like these little knobs. And this unified connection will become our TorqueFit connection. And unfortunately today, I don't have the time to actually go into the details, but if you're interested, please go to the booth and talk to our technical people. I mean, they will like to nerd out a bit. This is a fantastic connection that I think we really cracked a bit the code. It is slimmer, it is smaller, it is more tight, and it is more versatile. And I believe that this is, from a company perspective, the marvel of engineering that we actually achieved here. So with this said, I think we started to build our idea around how iEXCEL could look like. And you are aware of the BLX and TLX. This is now history. But what now will come anew is actually the BLC and TLC lines. And here I would just like to give you a very brief glimpse on what this comprises. Of course, more details later on also in cases and by other speakers. But in essence, first of all, yes, all those additional implant lines, they will host the new TorqueFit connection. And since this connection is more slim, we can also go slimmer with the implants. So in combination with Roxolid, we can go down to 375 for all indication implants. And we will also be able to go down to 3.3 with the same connection on the BLC. Now, having said that, we are also providing the larger diameter implants, 5.5 and 6.5, for specific indications. When you look at the endosteel shape, it looks very familiar. And this is on purpose. So we wanted to drive actually on the clinical experience that we had with BLT, which was very positive and strong, but we gave it a twist. So we made this actually a double lead thread, which is a bit more gentle to soft and medium hard bone. So it preserves the bone better and actually preserves more of the primary stability that you can get from the existing bone. And secondly, we enhanced also the cutting elements in order that in hard bone you don't need a tap anymore. The tip stays basically the same, is very slim, and particularly for patients with limited bone volume or converging root tips, the go-to implant in our view. And last but not least, and this is, Dani, what you often call the hybrid implants, the TLC versions come in different shapes and forms when it comes to the neck. So combining now our regular platforms that we know from tissue-level prosthetics with different diameters, we will have straight neck variants as well as these tulip-shaped variants. And particularly on the straight neck variants, and you will show this afterwards, Dani, there is a lot of placement flexibility in terms of how deep you want to insert the implants. So summarizing, iEXCEL will be the performance system of Straumann, combining 4 different implant lines with one prosthetic connection and placeable with one surgical kit. And we believe that with the lineup that we have now, we can serve a lot of the indications, be it from very short implants, there will be also a TLX 4mm coming, to very narrow implants, so the 2.9 BLT is incorporated and can be placed actually with the same surgical set to all the other indications that are covered. Now, we have spoken a lot about implants, but we will take the opportunity of the market introduction of iEXCEL this and also next year to incorporate a lot of prosthetic and also surgical innovation. Just picking out a few, when you talk about the prosthetic and digital workflows, then we have to give also the Variobase, which is one of the most used abutments, a upgrade. This will come, and we're also digitizing a lot of the workflow elements for you to be more effective. For example, anatomical healing abutments that are scannable, or then also for dentures cases, be it removable or fixed, there will be possibilities to improve also the efficiency. And with this, I would like to give you back the words, Dani, for some cases that you would like to show.
Yeah, thank you very much. I can tell you I got exposed 2018 to BLX. Also wanted me to use it, and I told them, also George was part of the discussion, I will never use it. I want to have a machined neck on top. That's how then TLX was actually initiated. And that's what I did then actually in June 2020, the first TLX cases. But I realized very quickly I had sometimes a little problem with that implant to prepare. Probably not good enough from a surgical point of view. I told them then soon after we also need the BLT implant with a machine neck. We called it at that time TLT, now it's called TLC, because it got then this excellent connection as well. So I use this implant for molar side sometimes, for short implants, because then the large thread compensates for the shortness of the implant with a larger surface and so on. But the real development from my point of view is the TLC, also the improved BLT to a TLT or TLC, and including also the torque fit. The torque fit is a much better connection, as you'll see later on. And we have two versions, straight up or tulip. Tulip looks like a tissue level implant, but the straight up is actually also a bone level implant. It's actually both. So it's a hybrid in a double sense, hybrid surface, hybrid prosthetic options. And this is, from my point of view, the real breakthrough and the game changer for us in daily practice. Because what you see here, two examples. One is with a tissue level prosthetics on the left side in the first premolar side. And this is one of when we finally were able to use it with a vario base, and this is now, of course, the bone level prosthetic. So this implant is now a platform switching implant, and for highly aesthetic case, that's very important to have. So this is the big game changer, that we have both prosthetic options available, in particular cases in the aesthetic zone, for sure. Okay, now I show you 4 cases. This is the first one we did in late night 2022. And you see the 1-year follow-up. This is a tissue level prosthetic, a little bit saucerization, as you see, typical GBR procedure, very nice outcome. And of course, we will follow this case. Here is a similar case I did with Ramona, my daughter. This is the first premolar, also GBR. And look how minimal the bone remodeling is 9 months down the road. I mean, this is impressive to see. Then we have a case here where we have done also, again, in the aesthetic zone, and that's now the first one where we could use the vario base for the final crown, not for the provisional crown. And you see how much that improves, of course. And then last but not least, here an immediate one, where we have to use vario base. It's much easier to produce the provisional crown. We're going to do one in 2 weeks in our upcoming GBR master course, and that really helps a lot in the clinical procedure when you do immediate cases. Now, when we conclude for the future, when you're going to have the full range of iEXCEL implants available, then this is a big improvement for daily practice. First of all, you can cover all indications with one implant system. Second, you can cover everything in surgical with one surgical instrument kit, not 3-4 ones. That's a big help also for your assistant who takes care of all these materials. The fourth one is that you have the same prosthetic platform. That means you can use the same impression technique. That's also a big improvement because we had a lot of discussion. The new TLC and TLX implants will reduce the risk of peri-implantitis because it takes the legacy of tissue-level implants. So when you get a little bit more bone remodeling, you will not get an exposed micro-rough surface. It is a smooth surface, also machined. That's a big one. I stopped to use 18 months ago bone-level implants at all because I use it very limited for aesthetic cases, and now with TLC I have even improved technique. My preference is TLC. The TLX I use in first molar sites, but I'm sure when I do the calculation in 2 or 3 years, it will be 80-90% TLC, and the rest will be TLX for cases I just mentioned. Now, what are the big advantages? I want to show you 2 of them. These are just case reports now. First of all, like with BLT, the surgical procedure is very smooth. You can insert the implant, it's very predictable, and you get a very good primary stability. I learned, and when we measure those iEXCEL, what's the iEXCEL value at day of surgery, then I figured out it's much higher than all the previous measurements we did. And you see here the top 3 are post-placement measurements, and the other 2, these are 8 weeks later. You see, iEXCEL values above 80 are very rare. Now, I have iEXCEL values often 93, 94, even 97, when it's unseen before. That means that they made a great job, the engineers with the thread. We tested 3 different prototypes. We had to do hands-on with this, and we decided on one, and that obviously was a really good one. The second one is that the torque fit connection must be a stable connection, because obviously the microgap doesn't play the same role as with tissue level implants, because the bone source is absolutely minimal. It's absolutely clear that we have to confirm that in large studies by university groups, but at 1 year and 3 years. And if this is the same what you see here, minimal bone remodeling and bone source development, then that is a clear indication how stable this connection is and that it closes the microgap. And last but not least, what I said before, the opportunity that I have in the future with one implant, 2 prosthetic options, tissue prosthetics, bone level prosthetics, it's made by the prosthodontist and by the dental technician. I think this is a game changer, in particular in the aesthetic zone, premolar size, whatever, and that really is a big help.
iEXCEL, from a surgical perspective, really stands for versatility and simplicity. Versatility because we're talking about 4 different implant lines, each one of them having their own specificities and advantages. And simplicity because these 4 implant lines can actually be used with the same surgical instruments, with one surgical kit only. Whether you want to go freehand or whether you want to place your implant using guided surgery, you will always be using the same drills. Not only the same drills, you will also be using the same surgical instruments, like for instance, the same ratchet, the same alignment pins, all the way to the same implant driver, as these 4 implant lines do actually share the same prosthetic connection. Let me now tell you a bit more about the implants. So as you know, as I just told you, iEXCEL is 4 different implant lines. But actually, if you have a closer look at the implant body, you will notice that we actually have 2 endosteel designs available each in bone and tissue level versions. If we start with what we call BLX and TLX, the X-line implants, they do share the exact same endosteel design. The only difference is the fact that the tissue level option, the tissue level version, has actually a machined neck on top. The same approach applies to the C-line, the BLC and the TLC, which you see now on screen. They have the exact same body, the same endosteel design, yet one difference, TLC has a tissue level neck, machined neck, while the BLC, the bone level option, doesn't. If you allow me, I'd like now to explain you a bit more also the differences between these 2 endosteel designs. I'd like to walk you through and explain what differentiates them, but also I'd like you to understand that we believe that they are very nicely complementing each other. If we start again with the X design, the BLX and the TLX, they have been engineered, they have been designed with one goal in mind, for them to excel in immediacy. Immediacy here is really the key word. As you can see on the picture, the implant threads are really active. And this has been done because we want them to really help you achieve the best possible primary stability in all kind of clinical situations, in all bone types. On the other hand, you have what we call the C design implants, the BLC and TLC. These are much more universal implants. We believe that with these implants, you will be able to always efficiently and safely achieve any kind of clinical indication you want to perform. Of course, if you want to go for something very active with the best possible primary stability, the X will still be the implant of choice. But for those of you who may prefer less active implants and still want successful and reliable results, then the C design implants will also be the implant of choice. Let's take now a few minutes to deep dive, to go one level deeper into the features and benefits of these 2 new endosteel designs. And let's start with the X implants, the BLX and the TLX, which, as I just said, are implants that have been designed to excel in immediacy. And immediacy means high primary stability. And to achieve high primary stability, there are several features that an implant needs to have. First of all, let's talk about the shape of these implants. BLX and TLX have slim and fully tapered implant cores, which allow for small and undersized osteotomy, as well as gradual lateral bone compression through increasing core diameter. Basically, what it means is that the deeper the implant will go while you place it into the implant bed prepared, the wider the core will be, therefore increasing stability. The second feature is linked to the threads of these implants. I talked about active threads. Well, basically, we're talking about, first of all, deep apical threads that provide a large anchoring surface for immediate engagement and improved stability. If you have ever tried these implants, or once you'll try them, you will really feel that they literally bite into the bone immediately after the first turn. The threads have also something we call the variable thread design. Just like the implant core is fully tapered, meaning it goes from something very thin to something much wider from the apex to the top, the same logic applies to the threads. We start with very thin and sharp apical threads, and progressively these threads get a bit bigger as you go from the apex to the top. This provides basically a progressive, controlled, and steady bone compression through this increasing thread thickness, and all of this in a steady manner. These implants also have bidirectional cutting elements that do enable direction control during insertion to achieve prosthetically optimal positioning. And last but not least, they do have a reduced neck, which literally eliminates the need for profiling, as well as facilitate the subcrestal implant placement. Moving on now to the C-design implants, which are our latest apically tapered implants. Let's talk about how they can actually perform in all indications in a safe and efficient manner. First of all, they do have a very slim apex. This is perfect for patients having limited anatomy, such as converging roots, facial undercuts, or narrow atrophied ridges. If we stay on the shape of these implants also have a tapered design, which is, unlike the X implants, a bit different. The X implants have a fully tapered body. Here we have implants that are slightly cylindrical at the upper part and then taper as you approach the apex. So this tapered design really enables under preparation of the bone and also ensure a high implant stability. Talking about the threads, here again, if we compare the C design to the X design, the philosophy is different. X is much more active, while the C implant have threads really fitting the osteotomy. Here we have a very reduced distance between the implant core and the thread edges. This has been done to facilitate, to enhance new bone formation. We then also have extended cutting flutes because we know that these tapered implants are often used also in hard bone. And to avoid bone compression, you need either to tap the implant, which is what you would do up until now, or with these implants, you would have actually these extended cutting flutes that have been designed in such a way so that tapping becomes totally not needed anymore. And last but not least, we're particularly proud of the fact that these implants are really narrow and short and really provide less invasive treatments. This is possible thanks to the combination of the short and small torque-fit connection, which my colleague Christian will tell you about in a few minutes, and the combination of these new torque-fit connection and the rock-solid material, which is our strongest material. So the combination of these two elements makes it possible to actually have smaller implants without having any compromise on the stability, on the resistance, of these implants. So basically the 375 diameter implant is now our smallest all-tooth indication. And we can also offer you small, short implants, 4 millimeter on the tissue level side, 6 millimeter on the bone level side. So to conclude with the surgical part of iEXCEL, I'd like to show you this overview summarizing basically how the range looks like from an implant perspective. You have all the fully tapered options, you have all the apically tapered options, basically the X design, the C design, with the bone level and tissue level versions. You can see that we have a variety of different lengths available. We have also short lengths on tissue level, 4 millimeter, 6 millimeter for the bone level implants, and you have lots of different diameters, 375 really being the red line across these 4 different implant lines, being the smallest all-tooth indication implants. But beyond figures, beyond dimensions, what I really would like to highlight again is that iEXCEL has been developed, as I just mentioned at the very beginning, with the objective to provide you versatility, so lots of choice, simplicity, so choice without having to worry about having too many instruments, without having to worry about having too many prosthetic components, as my colleague Christian will tell you about after. And all of this for the sake of your patients, for the sake of also your practice. You should be able to always select the most suitable, the most clinically relevant implant for your patient without having to worry about, do I have the right instrument? Or what about the impression component? What about this? What about that? Simplicity, versatility, but also focus on the patient, focus on the treatment. And last but not least, everything we have developed, everything within iEXCEL is, of course, digitally integrated. It starts with data capturing. We provide you lots of different options, all the way to the treatment monitoring via patient engagement, treatment planning, guided surgery, restorative options. So everything within iEXCEL is today digitally integrated. Thank you very much.
Hi, I'm Dr. Christian Jerry, Associate Director of Clinical Affairs from the Global Medical Education Department. It's a real pleasure to address the torque-fit connection to you. This is a topic very close to my heart. As a periodontist, I always like to plan my cases and finalize my cases, and I understand the importance of the connection in the overall implant therapy. In this note, also clinicians don't want to have to be creative to solve a case. They don't want to have to go through different layers in a catalog to find the right parts to build their cases. They don't have to, they don't want to purchase a large amount of inventory just to tackle each one of these platforms in one single case. And also over time, they don't want to have to deal with screw loosening potentially between mixed connections or eventually redos that is very time consuming and very costly. And all these different pain points that dentists have signalized on the Straumann portfolio, this is all gone with TorqueFit. Number one, we're addressing the multiple connections by shrinking down to one. So no matter if it's the C line or the X line, it's one connection all across. Also in between the lines, but also different diameters. So the small diameter implant, be it 3.3 all the way to 6.5, it's one connection. So you don't have to worry about thinking in between platforms, narrow, regular, wide. This is all gone with one connection. Does precise engineering and one connection make a difference in daily practice? Of course, a lot. This is a case from Alessandro Perucchi from Switzerland. You see this patient with an incredibly sad oral situation. It's a hopeless dentition with a compromised periodontal situation. When we look at the x-ray in the initial situation, when we look at all this planning, you will notice all the BLX implant. If you pay attention on the left side, was meant to be done on all implants in the upper with BLX 4.5. Throughout the surgical procedure, he could not engage one of the implants. He had to go from a 4.5 to a 5.5. This can be very tricky sometimes because if he was using a competitor's system, in that transition going from a 4.5 into a 5.5, he would have stepped into the wide platform territory. And look, he had planned for all regular. If he had moved to this situation and he did not have components to match the wide platform, that will be that awkward situation that you have to talk to your patient or to the referring doctor that, listen, I had to change the planning throughout the surgery, but I did not have adequate components at that time. And for this reason, you cannot be temporized or your patient could not be temporized because I would have to order components. With torque fit connection, it's one connection all across the board. So the surgeon had full freedom to navigate no matter the diameter, no matter the length. He could peacefully, throughout the surgery, choose whatever suits best the situation because he never crosses the line of the restorative doctor. You see how powerful one connection is? That's the beauty of the system. I will deep dive into each of these features individually so you understand why I'm so passionate about this connection. Number one, the Torx design. Torx design is heavily used in aviation and the automobile industry because it has an efficient torque distribution. It's a wise way to transmit forces. And on top of this, the Torx gives us 6 prosthetic position. When we talk about efficient force application, we see a lot out in the market, hexagonal connections or flat connections. When we engage the driver into this type of connection and we apply force during implant insertion, all we're trying to do is apply force outwards. As you can see an analogy next to the implant connection, you see the force application on the side of the car. That's literally what we're doing. You're barely pushing the car and you might run the chance of creating deformation and potentially fracture this implant. In Torx, the curvy design creates this almost perpendicular force that instead of pushing outwards, you're constantly pushing against the wheel. So it's an extremely efficient way to apply force. And why force application matters for us? Because we already know it's a topic of constant debates and consensus conference that torque value matters. So we tested in 35 Newton centimeters. It barely noticed any change in the connection. So we also extrapolated to 100 newtons and tested over 10 times. And guess what? From 35 newtons, that is the baseline for immediate procedures, for immediate temporization, all the way to 100 Newton centimeters, that is extremely high, the connection, we could not notice any deformation whatsoever. This gives us a lot of peace of mind to move forward, that we have a really of a refined piece of engineering in our hands to support clinicians reach their goals. As I just saw, we tested the baseline for immediate temporization, 35 Newton centimeters, all the way to 100 Newton centimeters. But we also extrapolated to see how much we could go. So we pushed the limits of this driver all the way to 285 newtons. And that was the moment when some changes occur. And guess what? It was not at the connection. It was the implant driver that broke. Of course, we noticed, as you can see in the left side, we noticed an uncontrolled fracture, an obliquous fracture. That is a no-go for us because this could lead doctors to an unsafe situation, having to pinch this out of the mouth, maybe inside the connection. So our engineering team redesigned the driver, and now you have a predefined breaking point in 180 newtons. This makes it very efficient, very safe, very reliable. And should you ever go, or your clinician go, to a really exponential torque value, maybe the patient moves or there's an arm force, and it should ever deform or break, it will break it at 180 newtons in a predefined point that you can just pinch it out and continue your surgery. The second element that I would like to highlight is the 0.1 flat top. This is applied in all the transitory components, be it healing abutment, temporary components, impression post. Why is this important to have a 0.1 flat top? First, you want to transfer this information to your lab. Should a doctor take a scanning impression, a digital impression, or a conventional impression, you want to transfer this information precisely to the lab. If it's a conical connection, it's very forgiving if you tighten more or less. It can be slightly deeper or slightly higher. With a flat connection, it's always precise, so this information gets precisely transferred to the dental lab for the restorative work. And second, by resting on the 0.1 flat shoulder, the conical connection is never disturbed. It's always preserved as tight as possible, as undisturbed as possible, for the final component to be torqued in once and for all. So you see there's a rationale behind each of the steps. The other feature I would like to highlight is of high importance is the 7-degree conus. This is a game changer for us because by reducing the angulation of the connection, we could reduce everything proportionally. Pay attention to this. By reducing the connection, we could maintain the wall thickness of the implant, however, reducing the overall diameter. You want to know what is the benefit behind this? I'll show you right now. When we look at the left, our current BLT with a cross-fit connection, you can easily see bottom up the differences. When we look at the implant, we reduced the connection, we reduced the overall diameter, right? Right. And this gives more room for biological space. So less metal, more bone. If we move one step up, by changing the angulation, we could also have a slimmer abutment. By having a slimmer abutment in the emergence profile, we could also have thicker tissue. We give more room for keratinized tissue to mount on this. You see that it's quite different than what we see in the CrossFit. The other feature, if we go one step higher, by reducing the connection, we could also reduce the overall abutment diameter. We give more room for the restorative material. This gives more resistance. So you see how one change, by changing the connection, we improve so many parameters. We give more biological space for the bone. We give more biological space for the gingiva. We give more resistance to the overall material and more aesthetically interesting look. What you see on this slide is a sequence of microtomographies representing an BLX implant 3.75 with a variable base on top. When we look at all the way to the left, it's baseline. No loading forces applied, just the component engaged onto the implant. One step next, we see 200 newtons force and then one more 460 newtons force. What does that mean? For regulatory approval, so we can safely indicate this to human beings to be used in human, we have to fulfill certain requirements. The first requirements, we have to prove that it sustains masticatory force. Every human being has a masticatory force on normal meals between 70 and 100 newton centimeters. So we have to push the limit. That's why we have to test all the way to 200 newtons. When we look at the image at 200 newtons, we see that it barely tickles. You see there's a lot of force, 200 newtons is a lot of force. You see maybe a little bit at the base of the component, a little movement, but zero opening whatsoever. Now, when we shift to one more, 460 newtons, so you understand what kind of force this is. Every time you have, for example, a pizza, and there's an olive in there that you did not pay attention, there was a stone in, and you give that bite, that accidental peak of force, that represents on average that 460 newtons. With this, in normal situation, you would just open your mouth and then you release the force, right? That is the same force that under a normal tooth, if it's a root canal done with a big restoration, that's a normal condition where you see the implant, the tooth will fracture, and this will be a potential candidate for implant. With the restorative component, we also tested to that limit, and when we push all the way, you see, double the force that is necessary for regulatory approval. Double the force. Keep that in mind. We barely see any movement inside. So you understand through this testing how the precise engineering makes a big difference in how this will be applied in real life. So you realize how this amount of precise engineering and biotechnology combined with biomechanical forces plays a big role in stability. This will dictate if this will be sustainable in the long run, if it will stay for long-term survival. And when we connect the dots into real-life application, that's always important we connect. So we see the combination of a slim implant, because we changed the connection, we could introduce a slimmer implant design. So you see a slim implant, the 3.75, the combination of 0.1 flat top, and then finally the 7-degree conus being applied and being a positive impact in real life application. Let's see how this goes. There was a century incisor that was hopeless. He had to be extracted. So you see the 3.75 implant right there. being able to be placed, allowing space for the hard tissue and soft tissue to be grafted. So you see a lot of biomaterial applied in the gap, also the connective tissue in between to maintain volume. And you see Dr. Marcelo Nunes temporizing this patient immediately, keeping the gingival architecture. That's what patients are looking for when they look for immediate procedures. After 2 months, you will see the beautiful emergence profile right there. But how is this possible? Now you see the shift between the implant connection and the 0.1 flat top. The temporary component could be removed without any wiggling, without the need of any force application. So you could just peacefully remove, soft tissue is protected, and you see how that soft tissue healed beautifully. You see a few biomaterials still trapped in the gingiva. That's okay. That's normal part of the dual zone technique. But if there's one thing that would never lie to you is the body. So if the body shows healthy healing process, that means the whole process was at peace, that the whole componentry was incredibly biologically acceptable. So by looking at that soft tissue, it gives me a lot of peace of mind that the narrow implant combined with the temporary prosthesis that was resting on the 0.1 flat top was extremely biologically acceptable by the body. Look how pink this tissue is. Now, moving forward towards the impression taking and digitalizing the model for the zirconia crown to be cemented onto the vario base. And when we look at the soft tissue condition of this patient just prior to having the final crown inserted, look how beautiful the gingival architecture got to be maintained and how the volume got to be maintained because less metal, more viable cells around. That's a piece of art and precise engineering being applied to the benefit of the patient. And when we screw that crown down, it doesn't get any better than this. Another feature present in a torque fit connection is a 22.5 degree shoulder. How is this beneficial? When we look at clinicians that would like to benefit in the posterior region of a wide emergence profile right off the base, WB wide base components will rest on the 22.5 degree shoulder. Please notice that the wide base component, when they rest on the 22.5 degree shoulder, it's not only there, they also engage in the torques, and on top, they engage in the shoulder. This combination of forces makes this component and this combination extremely strong and reliable. When we go back to those testing, we see how they play together. So you see the internal conus and the hexalobe all playing a good match. And on top of this, we have the force distribution on the shoulder. Now, if we switch to those testing, the 200 newtons and the 460 newtons, you see the presence of the robust, precise engineering playing a role in that context. So baseline, zero force, just a component on the left, and we apply 200 newtons force, remember I already discussed this, you barely see any movement. The component, the stack is extremely stable, like you have wings holding and grabbing onto the implant shoulder. Now, if we move one step further to that extreme peak that is similar to an olive stone or a cherry stone, and you apply that much force, yet by the angulation of the shoulder, instead of opening a gap, the tolerance of the component, instead of opening a gap, it just slides upward. With this, no gap is open in this type of stack. It's an extreme added value for a bone level implant, preserving the platform switching, creating this wide emergence right off the base. This is an extreme beneficial procedure for immediate placement in molars. Let's take a look at this. In the first in-human BLX placed in 2017, you can see Erik Salvensen. He placed in a healed site the BLX, and then he temporized a few weeks after. He temporized with a wide base component you see on the bottom right. When we remove the temporary crown, you see the soft tissue condition. Soft tissue doesn't lie, it's extremely pinky. Pinky is healthy and happy. This is an incredible outcome that we were able to achieve with the wide base component. Now, if we look at baseline, on the left, the patient had nothing. You see the stack representing in the middle how the restoration was finalized. This patient has been followed up as baseline, 1 year follow-up, and we have followed up this patient all the way to 5 years, and is now reaching 6 years, showing that this type of componentry That wide shoulder, if you want to emerge right off the base, preserving the platform switching, is extremely beneficial, and it's only present in the iEXCEL line. The last element I would like to talk to you about torque fit connection is a short connection. Torque fit itself, it's a short connection. This allows us to have short implants as well. If you remember in our portfolio in the BLT, we could only start our short implants in 8mm because CrossFit is a fairly long connection. In torque fit, this allows us to provide clinicians, to provide patients with reduced morbidity, patient centricity, because with this we could introduce the 6mm implants in this line. In a bone level line, we're starting 6mm, and in a tissue level line with the TLX, you will see also present the 4mm implants as well. Take home message, one connection all across the board, from narrow to wide, one connection. You're safe no matter what is your surgical decision. Torques, higher and efficient force distribution. You never run the chance of deforming or damaging your implant because of depending on the torque force that you apply if you're aiming for primary stability. 0.1 flat top, extremely precise vertically, and you never touch the inner conus. You preserve that connection virgin for the final component to have the final engagement, extremely precise, extremely fit, leading to a long-term stability. 22.5 shoulder. This allows for a wide emergence profile right off the base if you would like to count on this on wide implants on the posterior side. And the benefit, that is a short connection, reducing morbidity, being patient-centric, allowing for 6mm implants to be in a bone level line and a 4mm implant on a tissue level line. With this, I thank you very much. I hope you feel as excited as I am about torque fit connection, and don't hesitate to reach out should you have any questions. Thank you very much.
It's a huge honor for us to be here on stage, and I, periodontologist Algirdas Puišys, and my colleague Eglė Vindašiūtė-Narbutė, prosthodontist, we will share our surgical and prosthetic advantages, what we see or insights from this iEXCEL system. First of all, I would like just to come back to my first decade of my career. And in that time, let's say around 2009, like crestal bone stability was observed very, very rarely. So usually I saw 1-2 millimeter of bone loss, and of course it was even worse after some while. And also we just find the soft tissue also not so nice after some while. Again, crestal bone stability is something what we seek for. However, today's success criteria is still showing that 1.5 millimeter bone loss initially, and then 0.2 millimeter annually each year is like a normal thing. However, we clearly understand that if we lose this 1-2 millimeter of cortical bone, it's 10 times more stronger than spongiosa bone. And especially important when we use a short implants or in aesthetics. When we lose crestal bone, so we will see some recession, especially when soft tissues are thin. And more important, even more important, is the recent published data, and Professor Tanya Buzer already presented this. This is really something mind-changing, that early crestal bone loss may be predictor that after some while, the higher incidence of development of periimplantitis. 5 times you have more risk. So, of course, this is the goal what we are looking for. To have absolutely stable crestal bone and stable soft tissue. When we look to such good functioning case and break this case apart, we may find 4 consistent parts, like soft tissue, bone, prosthetic, and implant. And usually we discuss all the time how to augment bone, different procedures, how to deal and then manage soft tissues. And usually we somehow stay a little apart from discussing features of implant, because maybe sometimes it's not a good thing from bias thing because it's an industry. But in our opinion, it is the thing that we have to think about implant as a thing that influence a stability of our crestal bone and soft tissue. In the beginning of my career, I thought that implant, it can be as a screw, and everything depends on my hands and on patient and soft tissue and bone, and with each implant I can achieve the same result. In fact, today I don't think like this anymore. Why? Because when we look to all systems, what we have generally in the world, we may define and just put in a different boxes according to thread design, body shape, alloy surface connection, and neck design. And all these features may influence our stability and long-term result. Thread design and body shape, C-line and X-line, so BLC, TLC, BLX, TLX implants. So what do you have? We have like different body design, thread design, what helps us to work with the bone, not against it. In the same time, we get very good primary stability as well as not over-compressing the bone. And this is really very important when especially we do implants in immediate cases, etc., etc. So, generally speaking, if we want, we can use each of implant for all indications. Let's say if I am a fan of TLC or TLX, I can do it everywhere. Posterior, anterior, as well as with BL line, BLC or BLX. We may be also successful and succeed in aesthetic area and posterior as well. However, better and easier results, exactly what the professor already advanced about this, that healed side and the aesthetic area, I would go for BLC implant. And immediate in aesthetic area, of course, BLX. And the same in posterior area for heel side, TLC, and for immediate sides, TLX. So this may be some kind of guideline. And especially for me, as for surgeon, it's the easiest and the best thing that I have just one surgical kit for all 4 implant systems. And I can adapt it by myself, just thinking and analyzing in each case what implant to use. Secondly, alloy and surface. Again, in the beginning of our career, we just thought also, if it is certified, each implant is suitable for implant placement and it should work like nicely. Later, we realized, and also reading the scientific literature, that some of implants are made from pure titanium, means like up to 99% of titanium, and other part, it was like with titanium alloy, with aluminum and vanadium. And it was very interesting to note that osseointegration in comparison was really very good of pure titanium. However, strength was a little bit less, especially when it is not in cold work titanium. And we can see also many fractures of such kind of implants. And we see it also daily in clinical life, time to time, they have to remove broken implants. Titanium alloy with aluminum and vanadium, it has already much better strength. However, osseointegration is worse. So, until rock-solid alloy was not developed, so we observed also some strong implants, but to different reasons, when we needed to remove them, it is just, they unscrew. We joke like it is a beautiful systems, everything is okay, just one has, one disadvantages they have. They don't integrate. Rock-solid alloy, when it was developed, like trying to melt 50 to 50 titanium and zirconium, 60 to 40, 70 to 50, etc., and the decision was and conclusion was that 85% of titanium and 15% of zirconia shows best result. So we have best osseointegration of such alloy, as well as we have the best strength here. So that's why like already Dr. Ofer showed, by having this feature, we have the same thickness of wall, of the implant wall, we have more stronger implant. So, and 375 diameter is suitable not only for aesthetic area, but for posterior area as well. Additionally, when we look to aesthetic cases and when we think about bone and soft tissue augmentation, here is very nice illustration in this picture. I have two implants, lateral incisors were placed many years ago. We have 3.8 millimeter in diameter. Implants without platform switching, without conical connection, and they have the same platform, 3.8. And torque fit connection, 375, it has 2.7 millimeter inner connection, so the starting position. It means that we have this 1 millimeter more for our soft tissue thickness. And this is already a big deal, especially in highly sensitive aesthetic cases. So that's why this is like more preferable in aesthetic area. And second features like surface. Again, honestly to say, in the beginning I thought that SLA is so good or good enough that for me it's no reason to go and switch to SLA active surface. And I thought that this kind of marketing trick, just to do something and without any very important changes clinical, until I started to read and analyze it from scientific point of view. And these are few scientific papers and trials which changed my mind completely. One by Hodgkins and co-authors. They analyzed in vitro how does macrophages behave on different surfaces, titanium and rock solid, and SLA, and titanium and rock solid SLA active. And we found that titanium rock solid, rock solid and SLA active showed the best result by changing really immune response, the initial immune response in the beginning after we placed implants. What does it mean? It means that we have increased amount of osseointegration and we have reduced healing time. Okay? So, second paper, what was really, again, very interesting for me, by Frank Schwarz and co-authors. In this study, we just created defects and placed implants and just sutured over without any grafting, just leaving it for spontaneous healing on SLA and SLA active surface. After 8 weeks, it was huge difference between SLA and SLA active surface. So it means by spontaneous healing, by having and just adapting by blood clot, the healing was faster and better on the SLA active surface. And finally, by Edgar L. Char study, also with co-authors, when we created a defect around implant, 2 millimeter out and 4 millimeter in depth, and augmented with different materials, with allogenic and xenogenic materials on SLA and SLA active surface. And conclusion was again, and you can see here in the histological picture, much better bone healing, bone regeneration on SLA active surface. So these studies also was like mind-changing for myself, just to improve my daily clinical life and just change and switch to SLA active surface, just to use SLA active surface only. And here is unpublished data from our clinic, and we did just our statistics. In the first decade, we used RBT surface implants, a resorbable blast texture. Out of almost 8,000 implants, we lost more than 300. I mean, in the regular cases, when we have healed sites, we place an implant like nothing special, and it was failure of 4%, 96% of success rate. Some kind of good result. Then we changed to SLA surface, Straumann SLA. Out of almost 3,000 implants, the loss was 1%. Can you imagine? I place around 100 implants in a month. So 4%, it seems like not so bad, because 96% success is like okay. But out of 100 implants, it means in a month, 4 implants with failures. I had a failure once a week. By switching to SLA, I reduced this failure rate by 4 times, just 1 failure in a month. And then I switched to SLA Active, it was again 4 times less. Today, I just need to remove implant as a failure when not integrated implant once out of 400. It's 0.25% only generally. So it's like happening 2 or 3 times a year now. So this was also a clear improvement for myself. And finally, what Dr. Ophir just mentioned and just instructed very clearly about connection and neck design. I just repeated the influence on crestal bone stability. Because after we create soft tissues vertically, horizontally, as well as keratinized and attached tissue, when we need to protect and to seal everything with our implant and prosthetics. So, neck design. In the beginning, I thought that also we have just 2 designs, like tissue level or bone level. However, this bone level may be also different kind. It may be parallel wall, it may be convergent or divergent. And immediately we start and place implant with divergent implant neck. We have to prepare bone really very, very precisely. If only we just turn it a little bit more, immediately we will overcompress the bone. And we know what happens when we overcompress the bone. It means that we just make more tension, more destruction, so we have less blood supply there, we have more acidotic environment there, and this leads to more and higher osteoclastic activity. So, and when we usually observe a huge crestal bone loss, even implant is with platform switching, even microgap moved away, etc., etc. So having a parallel and convergent neck helps for us not to overcompress a cortical bone. And second thing is connection because of bacteria contamination. If we have pump effect, if we have not stable connection, if we have a microgap with a big size or microgap close to the bone, we will have a bacterial leakage. So that's why when we talk about connection, we have to look for very good stability. And again, when we take all implant systems in the world, we can put them into 4 boxes, like external or cylindrical, external or internal hex, and conical. Conical up to 6 degrees, we have like cold welding, like very, very tight, we have a friction, and 7 degree and more, we have a good conical precise connection. If this connection is not stable, so immediately we will see bone resorption. If we have already stable connection, second thing is microgap size. And again, with 7 degree, what we have on torque fit, with 7 degree conus, we will have a most precise, but still without a friction connection. So it's easy to take, and then we can talk a little bit more about this easiness of prosthetics. But this connection is very precise and very tight. Here I would like to share one doubt, what I raised in the beginning when this system, 5 years ago, a system was released. Because the conical connection, everything is okay, everything is clear. But this 0.1 millimeter sealing for other parts was a thing where I was really very doubt about that. And I thought that if I leave my healing abutment or temporary abutment with temporary crown for a longer period of time, I will have some bone remodeling from bone loss because my connection is subcrestally, and if it's 1 millimeter or is 0.1 millimeter will be not tight enough, I will see also bacterial leakage there, and I will have crestal bone loss. However, after 5 years of using the system, I can only confirm and observing all these cases that there is no problem at all. This 0.1 millimeter is absolutely enough. Only one thing what we are doing all the time when we take one part to another, changing course all the time using chlorhexidine gel just to put inside, because inside we have a lot of space, and if some saliva or some blood dot comes inside, So we may have a lot of infection later in that area, okay? And the last thing, but not least, of course, it's microgap location. Microgap location. In TL, tissue level implants, of course, it moves above a bone. And this is the best thing because we have a microgap above a bone. And this machine surface already connects with connective tissue, and it's the best sealing. Histologically speaking, it's absolutely the best implant tissue level for soft tissue sealing and protecting the bone from oral cavity. If we go and talk about BL, bone level, so platform switching. And again, by having 7-degree conical connection, this will be the biggest platform switching. So summarizing all this, having straight and convergent neck design, conical connection, stable connection, and the smallest microgap, and the biggest distance with microgap from the bone, we will have really a best bone level implant to have a very, very stable crestal bone. And if we place implants subcrestally, we will see bone remodeling, but not bone loss. Now, before I go to prosthetics, the last thing, by having such tight, just 2.7 millimeter conical connection in our starting position, I have to think as a surgeon and plan according to future prosthetics. Because the biggest problem usually what happens when we are using bone level implants, especially in posterior area, when we place them too shallow, not deep enough. And here we can see an over-contoured prosthesis like a mushrooms, and when we have not enough vertical soft tissue height, and when we have problems. If we respect this, so we need like height for our crown, plus we need additional height for biological width. With this, we will end up with absolutely stable crestal bone for many, many, many years.
So my part will cover and I will talk about the prosthetic part. So I've been working with Straumann for more than 15 years, and it's always been a system that keeps improving and upgrading the products. So the latest improvement, as you all know, is the iEXCEL performance system. And what is the main benefit from the prosthetic part is that the company is trying to make prosthodontist life easier. So my colleagues before talked quite a lot about different implants, about the torque-sit connection, which is really nice. So today, my goal is to talk more about clinical benefits of this new performance system. Probably all of you had those situations when you plan, for example, an immediate temporization. You have all the copings, abutments necessary for the clinical case, and then your surgeon gives you a message that, even everything was planned, something has changed, and the implant will be a little bit different. And I am that type of a prosthodontist who is a little bit raccoon. So I like unpacking everything in advance. So what happens? I have quite a big problem where to put all the stock. So now, finally, I am implant diameter free, which makes my life quite easy. So that's one goal. Another goal, because if you see in this slide, from 3.3 to 6.5, I can use the same abutment. So that means all the immediate temporization is easier. Then, in general, my stock, which I have to have in the clinic, is a little bit less. And also, when we are talking with my dental technician, it's also easier because he or she doesn't have to take a very difficult solutions to select, let's say, the abutment, which sometimes might be not correct for an implant. So that's why for me it became really, really easier. And it's the same with TLC system or TLX. I mean, I have the same connection for all the diameters. only I need to see what the platform is. So that's why if the surgeon is changing the implant diameter at the last minute, let's say for me, it's not a problem. From the prosthetic part, what is really important, and I think it must be followed not only with the iEXCEL protocol, but also with all the others. So that means that when we talk about the successful prosthetic part, which also gives an influence on an implant, it's about cementation or screw retention, then about the material, definitely correct shape, and definitely about the correct abutment. If we follow all those, we can have a very successful and stable result for years. When talking about the cement issues, me and Algirdas and our colleagues been working in cement field for, again, almost 15 years. And one of our latest studies, again with zirconia, with polystyrconia, showed that it's not possible to clean all the cement. So that's why we want to go for a screw retention. Then when we are talking about the material, and if we want to have a very biocompatible material, I want to have a proper abutment selection, and then I want to have polystyrconia, very polished, super polished zirconia, under the soft tissues. So then I can get a very stable result, which is nice to the bone, and then is nice to the soft tissues. Talking in general, from the very beginning, I need to follow the healing abutment of the same height. Then, if I'm doing the soft tissue conditioning with the temporary abutment, the same height of the temporary abutment. And finally, I need to go for the same height with the final restoration and with the final abutment. What is very important here that sometimes we miss the third part. I mean, surgeon, prosthodontist, definitely patient, but also technician. So that's why the technician can advise you what to select, but you need to give him or her a very precise recommendations and clinical information. What kind of abutment, which usually is selected due to the bone, should be chosen in every case. And what we need to do, we need to, as I said, follow the bone profile and follow the soft tissue profile. And when I have an ability to choose from 1.5 to 3.5 of every abutment healing gingival height, it's really nice because then it's easier to perform a stable result, which in long-term perspective is okay. And every time when we are talking about the selection of the titanium base height, of the barrier base height, it definitely needs to be selecting according to the X-ray. So especially if your surgeon is placing an implant subcrestally, which again is very nice, I need to know the bone profile to select the correct abutment. So in this case, you see this, the shortest abutment. But there are quite many cases when I need a very high titanium base. And it has been scientifically proven that the height of the titanium base has a very huge impact on how successful your final result will be. And sometimes when you don't share the correct information with your dental technician, I mean correct information usually is an X-ray of the bone profile, the technician does whatever he wants to do, and if clinician doesn't have enough competence to check if all is good, we have a problem with perio problems. I mean, periimplantitis might occur due to the bone pressure, and then we are not, we don't know how much the bone might resorb. So that's why we need to select a titanium base with a different gingiva height, and also to prevent some mechanical problems, we can choose the customized abutment height from 3.5 to 5.5 abutment inside, which gives us opportunity to give more support in the restoration. So I want to share one clinical case when we have a single crown, we need to extract a tooth, we are doing the immediate temporization, and if we follow a protocol with an implant, with the soft tissues, if we place it lingually enough, if we select the correct titanium base, if we select the correct zirconia, polyzirconia under the soft tissues, we can expect that the result, the final result, after a few weeks will be way better. And what is very interestingly and surprising, that even with some time, the soft tissues will improve. With a single crowns, everything seems to be okay, but I got quite a lot of questions what to do with the bridges, because you cannot go directly to an implant due to the fact that it has a conical connection. So that's why we have a few possible options for bridges. So first one, if you go with an BLX or BLC system, you can go with screw-retained abutment and barrier base with hex. Let's say if you have a very good implant parallelism, if no, you can always select a different angulation of the multi-units from 0 degrees to 30 degrees. And also what is important, that you always leave enough space for the cleaning. And having this in mind, we have a stable result. That's 4 weeks post-op. Another option is that we can have BLX or BLC, again, with screw-retained abutments or multi-units, and barrier base without hex, if I have more implant, and if I have more angulation. So again, with more implants, it could be a solution. I can have, for example, 2 TLX or TLC implants and only 1 BLX or BLC implant. And again, it might go with SRA if, let's say, the angulation is not perfect. So all the clinical cases, again, depends on how much you know about the system, but this system is really becoming very prosthodontic friendly, and all the solutions are quite easy. And the last but not the least is if you select barrier base 1 with no hex and 1 with hex. Of course, we are talking here about TLC or TLX system because everything is at the soft tissue level. And for me as a prosthodontist, also very important that these implants have a rock-solid alloy and they have a wider neck, even though the implant diameter is quite narrow. So that's why the prevention of the neck fracture is minimized.